When it comes to pulmonary patients and things that may make you think of asthma, a URI, just know that cough, congestion, viral 90% time, possibly atypical germs, but for the most part, URI, cough, viral. Now the virus hits multiple areas at once. Think cough, cold, congestion. Bottom line is if you have pneumonia, it's very focal. It's not the same thing. If someone has a strep throat, it's a red hot poker on their throat, fever, headache. If you have a URI, cough, ear pain, runny nose. Okay, so we'll talk about that more later. You're gonna leave here very, very well knowledgeable about bugs and drugs, the primary infections and the antibiotics that go with them. And just bacteria is more foci. Now, acute bronchitis implies they're not a smoker. Acute bronchitis implies they're not a smoker. Cough, congestion. Now, I'll tell you this, the textbooks I'll say, if the sputum is yellowish green, it is not correlated with bacterial infection. But most clinicians treat that. Most clinicians don't like, you show them like this and it looks like something that might start crawling. Z-Pack, okay? If you guys want to crack up, there is a company that puts out what's called algorithms of reality. Okay? It's not evidence-based medicine is what we really do. They have an algorithm of reality, a poster for acute bronchitis. Quite frankly, it's very funny. The first box it says, is it you or a family member? If it is, prescribe antibiotics. If not, how are you feeling today? Are you in the mood to describe the difference between a virus and a bacteria? If yes, if not, prescribe antibiotics. What's your patient's intellectual capacity? Can they understand the difference between bacteria? If not, okay. It's disruptingly funny. It's disturbingly funny because I'm like, should I do that? Okay. Okay. Inflammation. So basically, they'll have rhonchi, often clears with bronchitis. Typically, if it's bronchitis, guys, I don't have to do anything. I don't have to test. No antibiotics. When would I pull the trigger on antibiotics? If they're a smoker and COPD, I'm going to. When else? A good general rule, 7 days. Just like sinusitis. Sinusitis and bronchitis, going on 7 days, it's reasonable to treat. I would say this, if they're immunocompromised in any way, shape, or form, diabetics, treat. Also, and this isn't my opinion, these are the recommendations, elderly. Treat elderly faster. They decompensate, they go bad. So elderly, immunocompromised, smokers, okay, have tendency to treat quicker. Now, yes, ma'am.
Would asthma be like a lethal thing and getting worse with COVID? What about racial groups, like genetically, black people tend to get more hypertension? Is there any black people in your city have worse asthma?
I don't know. I did a talk this summer on hypertension. I look at the racial disparities with hypertension. It's legit. And what my colleague is saying is important. I just don't know the answer. Let me just share this with you guys because I think it's important. We'll talk about it later. Just know that when I hear about racial disparities and the racial inequalities in medicine, my gut response is, well, that doesn't really apply to me so much, but I think it's important for other people. That's kind of what I know it's probably important. I know it's probably a big deal. And I have a tendency to maybe, in a way that I don't think is responsible, maybe just go, maybe it doesn't mean me. But I'll just tell you personally, I was in combat. I was in combat against people who didn't look like me. And I was trained to kill people who didn't look like me. And I shot at them, they shot at me. And you don't think that didn't create some garbage in my head? It did. I'll tell you it did. And when I got back and I started taking care of people who didn't quite look like me and kind of look like someone I was taught to depersonalize, there was some things I had to navigate. So just know what my colleague's saying is important. I don't know her answer, but I'll tell you that this is something we all have to look at. And I'll tell you right now, the people who are the most prejudiced and most biased are the ones that think they're not. And I'm saying, just take a moment and just check yourself a little bit. If truly, we are all prejudiced and we're all biased. We're humans. There's nothing wrong with that. What becomes wrong is when you don't acknowledge it, you live in denial and you do treat people in a way that you wouldn't treat other people. That's truly the essence of prejudice. So I don't know the answer to that, but.
I just meant genetically, like Navajo Indians get, diabetes more, certain.
Yeah, I don't know. I still don't know. So I believe you. I'm good. I'm with you. Don't know. I just don't know. I don't know. Now, time out. Sanford's Guide. Who in here is familiar with Sanford Guide? Okay, bottom line is Sanford Guide of Antimicrobials. It is a little book on the medical bookstore that you can buy on the counter. Don't buy it. It's horrible. It's like fingernails on the academic chalkboard of my soul. you try to read, you're like, no. I get nystagmus and I start having pseudo seizures. I need a comfort animal. Bottom line is though, the app is excellent. The app is so good. Here's what I'd submit to you. If you get the app, it's $35 a year, and don't prescribe anything if it's not aligned with the app. And if you do it that way, you'll never be wrong. It's really clean. It's really easy to use. So bronchitis, self-limiting inflammation of upper airways due to irritations or infection. This should be distinguished from small airway, which is pneumonia. Consider pertussis, which we're going to talk about in a second. Sputum, purulent sputum alone is not indication for antibiotics. Cough may go on for 3 weeks. Fever and chills, do a chest x-ray. That's the indication. Fever and chills, do the chest x-ray, okay? Be aware of something, guys. Mycoplasma chews the crap out of the epithelial lining upper airway. You can kill the mycoplasma or it can die, but it takes about 2 to 3 weeks for the epithelial lining to grow back. So they'll still cough. I'm still having a little residual cough from something that I picked up 2 or 3 weeks ago. It's just my epithelial tissue growing. I don't believe I'm infectious, it's just my body healing. Now, bronchitis, what do? Antibiotics are minimally effective and are not indicated. Just so you guys know, meta-analysis of all the data. If you're a non-smoker, do you get better on antibiotics for bronchitis? Yes, only by 0.6 days when you look at all of the data, which means about 13 hours. Okay, you get better, but it's not worth it. Not worth putting your body through antibiotics and the cost. So pertussis is the exception we'll talk about in a second. Now, antitussives, guys, just so you know, dextromethorphan is a cough medicine. It's just as good as codeine. So Robitussin DM. Dextromethorphan, it's an antitussive. Does it help? Little, maybe. Maybe there's little evidence. Just know that dextromethorphan is a very close isomer to phencyclovine, which is PCP. So if you have someone who takes Robitussin DM and they have to get tox screens, they could pop, okay? May be inhaled bronchodilators and inhaled corticosteroids sometimes. Now, the efficacy has not been systematically evaluated. Bottom line is, here's the best we have.